We now move on to a presentation on evidence and experience in planning for interventions by the NIHR Global Health Research Group on Homelessness and Mental Health in Africa. So we're going all the way to the African continent. I now invite from the HOPE team, Dr. Ribka Berhanu, Assistant Professor of Psychiatry at the Addis Ababa University and the co-PI for the HOPE project. Please come up on stage. Ms. Eleni Miskanau, a mental health advocate and co-lead for the HOPE community engagement. Dr. Caroline Smart, project manager for HOPE. Ms. Lauren McPhail, the project coordinator for HOPE. And Ms. Kimberly Karuki, Africa Mental Health Research and Training Foundation. They will now present on the HOPE project, which is an international collaboration between researchers and people with lived experience, policymakers, and community stakeholders working in Ethiopia, Ghana, and Kenya to develop effective rights-based interventions for people who are homeless and have severe mental illness. I now hand it over to you to do your presentation. Thank you.
Okay, good morning. We're here to present or introduce our project called HOPE. Aptly, I would assume. It's in direct, we're in direct connection with the Benin, I think. So it's a tough presentations we heard to follow from a very high income country to our low and middle income country projects. Just to introduce us, we are an NIHR Global Health Research Group on homeless and mental health in Africa, just as mentioned. And this is our group. It's a vast group, but we are here to represent. So our agenda will be, I will give a brief introduction about what's HOPE and what we're planning. And Lived Experience Advisory Group, our league, will be presented by Eleni and Kimberly next. And local evidences and what we're doing will be presented by me next. And our global evidence will be discussed by Lauren and Caroline. So just to start, the aim of HOPE is to develop an effective and rights-based interventions that respond to the needs and preferences of people who are homeless and have severe mental illness in Ethiopia, Ghana, and Kenya. It was started in September, and now it's still going. And the plan is it will end on the August of 2026. As mentioned already, it's an international collaboration between researchers, people with lived experiences, policymakers, and community stakeholders working in the countries I mentioned already. So this is our main objectives. At the heart of HOPE lies people with lived experiences. And we work by the principles and values of community-oriented, rights-based, participatory, and contextually relevant evidences. Our hope is not to just provide research or data that we think is relevant for our society, since we want to make it, there are so many evidences worldwide, we want to make it contextually relevant to the community that we are providing. Another principle we are working on is to strengthen capacity within, we have researchers, we have peer researchers and postdoc researchers. We want to build coalitions, which we are doing ongoingly, and co-produce and test interventions. And again, we want to provide evidence that works and how much it costs. And also develop methods and ethics. And in the long run, influence policy and strategies that could be used to have a how-to guide to do the interventions with homelessness and people with serious mental illness. So this is HOPE in one slide. We are now at, as you can see, it has a formative phase, a co-developing and piloting phase, and implementing and evaluating phase. We are now at the formative phase, We have done the Gray Literature Synthesis and the Delphi Consensus, which will be presented later on. We are also doing, and it's an ongoing process, we are doing the context mapping, and the ethnography will be is being finalized. We have done most of the work for the survey. We're in preparation. Hopefully in the next few months we'll do the survey. So this is our formative change. And while compiling this information, we did the theory of change. And I'll present what our theory of change later on. So after having this information, our plan is to adapt and develop an intervention and select implementation strategies, then pilot this using participatory action research. And then eventually the intervention courts and case studies, and we'll know what works and for whom and where. At the end of the project, our impact will be an improved health and well-being of people who are homeless and have severe mental illness. We'll have a manualized open source interventions and how-to manuals. While doing this, as I said, we have engaged with people with lived experience. We have peer researchers from people with lived experience, and we are developing small grants and research. So while planning our intervention, there are, as I mentioned already, just to explain in general, there are so many sources of information we are trying to compile. We want to have ethical, rights-based approach. So as I mentioned already, lived experiences advisory group is in the center of our research project. And to get the international information, we have the context mapping and in-depth interviews, the systemic review, and the Delphi. And to see what the preferences and needs and priorities are, we're doing the ethnography. We did multiple stakeholder meetings and theory of change, which I'll talk about more in detail. And we're planning to do the survey. And compiling all of this, we want to develop an intervention which is acceptable, ethical, impactful, and which is feasible for our community, and that's sustainable interventions. Because most of the data or evidences we have already are global evidences, and it might not fit with our resources and with our culture. So we want to develop an intervention that is contextualized and that's sustainable for our community. Oh, okay. And now Eleni will give us some experts by experience.
Hello, everyone. We are people with lived experience of a mental health condition. We have formed what we call the Lived Experience Advisory Group, which is not formed as an afterthought, but which is part and parcel of the research project. Some of us are already engaged in the proposal writing stage. We were part of the drafting team. So this is a conscious and innovative approach to include persons with lived experience in the HOPE project. We have regular monthly meeting since November 2023. And our input is really considered as an expertise, lived experience being considered as an expertise on its own. And our input is very well received in the investigators meeting, which is held monthly, and in other community engagement activities. So one of our input was to inform the research methodology of the project. We have given very insightful inputs in the ethical considerations, especially during the ethnographic research. We have given input in how to navigate consent issues when someone on the street is being observed without their consent. And we also provided insightful feedback on the cross-sectional survey methodology. So we have given inputs on the measurements that will be used for the cross-sectional survey. And we are also part of the team that is doing the cross-sectional survey, giving inputs as to the will and preference of the person, especially in the case of non-capacity to consent. And we have also provided expertise in the theory of change, especially at the development stage. And some of us are also involved in the peer research activities. We have not yet decided the title and area, but it's coming. And we also intend to publish our experiences as advisory group to the project. And we have also been engaged in public engagement activities. We are part of the community advisory board that is giving input to the project every 6 months. And we are also part of the country management group, meeting weekly. And we have also given social contact during training sessions of health professionals that are going to assess the status of people, especially related with the cross-sectional survey. And peer support is also considered as an intervention outlet. So we have been taken peer support training, which is trainer of trainers, and currently we are trying to recruit people with lived experience of homelessness to be part of the league, the lived experience advisory group. Thank you very much. I have here Kimberly from Kenya. I am from Ethiopia, which will be giving us some of her thoughts. Thank you.
Thank you so much for that, Eleni. Hi, everyone. I am Dr. Kimberly Kariuki, and I am so honored to be here on behalf of, thank you, on behalf of the HOPE Kenya team, as well as the HOPE Lived Experience Advisory Group, LEAGUE for short. Caroline, Eleni, and myself represent half of the HOPE League as it stands today. So as Eleni mentioned, as well as participating in the proposal reviews and securing ethics approval, League members have actively engaged in consultative meetings within the project, including the bi-monthly investigator meetings, the quarterly steering sessions, quarterly steering committee sessions, and the annual general meetings. We're currently in our second year of HOPE, and the last meeting was held in March in my home country, Kenya. Capacity strengthening is also quite integral to the project, and so HOPE has prioritized continuous professional development for the members of the League as well. In the first year, we undertook training in ethnography, research methodology, ethics and safeguarding, and we also did theory of change training, which was to, of course, ensure that we could contribute to intervention co-production. And this, of course, has also lent itself to ensuring that our input is valued in evolving research methods along the way. In our second year, we have undergone training in the foundations of peer support, and we're also currently enrolled in a community engagement and inclusion course, the aim of which is to enhance the value, relevance, and conduct of health research by engaging and involving the community throughout the research process. This is a course that's offered free by the NIHR. And we also have an upcoming writing workshop that we're looking forward to. So overall, as the League, we will have enriched experiences throughout this project, and we will be community engagement and inclusion practitioners, as well as trainers of trainees and peer researchers as well. On behalf of the League, I'd like to thank the Banyan for having us. Thank you so much.
Thank you, Eleni and Kimberly. So I will go on to talk about what we are doing so far, about the theory of change and the context mapping. To start with the context mapping, we are doing context mapping in Ghana, Kenya, and Ethiopia. Unfortunately, my colleagues from Ghana and Kenya couldn't make it, but I'll talk about what we're doing in Ethiopia. So what we did was first identify which areas in Addis Ababa are densely populated areas. After we did that, we had a meeting with we developed a community advisory group. I'll show you the pictures and discussed with them in detail. And then we had a meeting with some governmental and non-governmental organizations and associations and identified what's already being done to help individuals who are homeless and who have a serious mental illness. And we did also a proactive community identification activities. This included having trainings, multiple trainings for health workers who are not actually engaged with this population previously. So we did multiple trainings, including, we just did not train them on identification of what's mental illness or not. We had trainings that involved about stigma and discrimination and how to approach individuals who are homeless. We could have used that raw ideas, but we'll learn from that and then approach it. Which was so different about this trainings is we used our lived experience in colleagues, which showed a major change in attitude and how they perceived what mental illness is and what homelessness is and how to interact with those individuals. And the training resources from a different project in Ethiopia was adapted and implemented. This is the country management group I mentioned earlier. While this is a group of individuals from governmental organizations, non-governmental organizations, some are religious leaders, and from organizations that are already doing work in this population that we're doing. And after this discussion, we came about which areas in Addis we should work in, the ones that are densely populated, which we operationalized a definition of homelessness, because in a country like ours, there are so many problem areas, so we had to pinpoint what we're calling homelessness in this discussion that was made. And the country management group, which is from the community, is responsible to make us accountable, and every 6 months they would meet and regulate what we are doing. So Hope, our main objective is to involve our community. Instead of saying that we know, here are some evidences that we know, do this. We want to get the evidence. Before getting the evidence, involve the community to see what the needs are, what their priorities are, to develop evidence. This is another group that we have, the Community Advisory Group. This is a group of, again, some are governmental, some non-governmental, but there are also police and religious leaders that are involved in this group. So while doing this group, we introduced HOPE. We introduced what is mental illness, some signs and symptoms about mental illness, since some of them were not aware. So when we come to theory of change, I just want to say a couple of things about what theory of change is. Theory of change is an outcome-based approach, which is specific to our program or to any program. It is task specific and it's participatory and it's outcome approach. There's an outcome we want and how to get that outcome we discussed. Based on this, we had a different meeting to develop our theory of change. We had some idea of the impacts and the outcomes we wanted, but we, again, had community members from different organizations that are already working in mental health and in different governmental sectors. So we had the discussion of what outcomes they wanted or what outcomes they want to see. Of course, some of the outcomes that were mentioned are beyond the capacities of HOPE, and it was beyond our ceiling of accountability. But most of them, the outcomes they mentioned, was put into our it was put into the theory of change map. And some of the interventions on how to get the outcomes were also included. Here is our theory of change. I don't think it's quite visible in the slides, but it's already, the poster is over there. Maybe when you go around, you can observe it and talk to us if you have any questions regarding that. Just to give a brief summary of the theory of change, it looks really busy now. It looks really crowded, but it didn't start crowded, and hopefully it will not end as crowded as this. This is our second draft of theory of change. The first one was after our workshop, and the second one was after our annual meeting in March in Kenya. So just to say some of the outcomes. Our short-term income is to have committee members have an increased awareness, positive attitudes, and involvement in supporting the needs of people who are homeless and have severe mental illness and their families. Another is agencies and organizations who interface with people who are homeless, are aware of mental health needs, and services have positive attitudes and integrate their responses to the other agencies. The other one is Women and Social Affairs Office have an agreement on insurance-based healthcare for people who are homeless and have severe mental illness. Just to explain about that, our healthcare system in Ethiopia currently completely avoids this group of individuals. The most vulnerable individuals are being excluded because for us to have an insurance, you need a home. And if you don't have a home, you don't get an insurance. So completely avoided. People who are homeless cannot get any sort of medical or mental help. So just to mention what happened while we were doing an ethnography, there was a woman who was homeless, and she had a baby as a product of an assault. She was living in the street, she got assaulted, she had a baby. And when she abandoned her child for some reason, she did not divulge, the police took her child. And she had some behavioral change while she was living there. But whenever she's seeing other kids in the streets, that were about the same age as her child, she started to have overt symptoms like disrobing and walking naked. So we said this is a risk. We can't have her walking naked. So we wanted to provide some sort of psychiatric help, have her housing and other any kind of involvement with us. But when we want to take her to the to mental center, nobody was able to accept her because she doesn't have insurance. And we wanted to get her insurance, and insurance was only for those who have permanent housing. So while we're trying to figure this out, in the midst of all of this, she changed where she was staying and we couldn't find her. So these are the kind of complex issues that we are seeing. That's why we had the Social Affairs Office have an agreement on insurance-based healthcare for people who are homeless. So the other outcomes that we wanted to see is after this, people who are homeless and have severe mental illness will have a basic needs met for food, water, and clothing. The other one would be community, formal and social services and integral services are accessible to people who are homeless and have severe mental illness. The other one would be people who are homeless and have severe mental illness are not exposed to abuse from the community members. So I will not go in detail with everything because you can't look at it and talk to us if you have any issues. But just to mention, at the end of all of those interventions, what we want to see is people who experience homelessness and severe mental illness can live with dignity and have an improved quality of life. So the color codings are different for all of them. It's described in the chart. So due to time, maybe now the global context will be discussed by Caroline and Laura.
So as well as the local evidence, we've also been interested in the global evidence. So we have conducted a systematic review. So looking at what evidence exists on interventions for people who are homeless and have severe mental illness in low and middle income countries. And we had a cross-country team working on this. So we had our colleagues from Ghana, Kenya, Ethiopia, and the United Kingdom. And we included both peer-reviewed and grey literature. And we have found 33 programs. A significant proportion of those have come from India, and much of our sources are from the Banyan. And unsurprisingly, the key finding that we have found is the importance of multi-sectoral and integrated approaches to support homeless people with severe mental illness in low and middle income countries. And our current stage is drafting the manuscript. So hopefully we will have a published paper in the next few months. We've also been, we have an ongoing Delphi consensus exercise. So we're looking at best approaches for programs for people who are homeless and have severe mental illness. And this is, again, low middle income focus, but we are also including global actors. And we're drawing on experience and evidence, in particular, local evidence and lived experience. And we are doing 3 rounds within our Delphi, and we're currently at round 2, analysing the results and drafting the 3rd round. So Caroline will talk to you a bit more about the Delphi process.
So in the Delphi, I say Delphi, I don't know why, consensus exercise, the first round, it's listed here. Okay, we asked participants to list all the important components of programs that support people who are homeless and have severe mental illness based on their experience as experts in the field or people with lived experience. We then pulled together the responses and identified 7 domains of intervention components, which we'll talk about in a minute. The second round, we asked the participants to score each component based on importance and feasibility, which we operationalized in low and middle income country settings, and to add any possible interventions or intervention components not yet listed. And we asked their opinion on the relative weighting of importance and feasibility as to inform the third round. So the third round is yet to be set out. It's in progress as we analyze the round 2 data, and we would really appreciate anyone in this room feedback and involvement in helping us to complete this exercise. So the domains that emerged as findings were around basic needs, food, shelter. Healthcare is a basic need, but we separated it out into another domain. Outreach and engagement with people, service models of care, empowerment, community level interventions, and macro level interventions. So we started to analyze in this way. And then when we sent out the second round, just to say that we found 118 different components. So it didn't take too long, I don't think, to fill out, but there was a lot. So this is just the graphic here is just a very small part of sort of the top listed or rated intervention components. So this might be a little bit difficult to understand, but these intervention components are scored highly on both importance and feasibility, but the scores presented are mean and median responses. So the way that we asked the question was based on a Likert scale of 1 to 5. And you can see that we didn't even include the 1 because no one said that they were unimportant components. So 3 would have been neither important or important, 4 would have been important, and 5 would have been of utmost importance and or feasibility, depending on how we split the question for the component. Sorry. So as you can see, it's almost all 4s and 5s. And in the final 3 columns, we have the mean and then the median score in importance, and in feasibility, it's just the mean score. And you can see the domains as well. So in the third round, do we have a slide for the third round? No. In the third round, we're going to ask our participants to reflect back on, again, importance, relative feasibility, and maybe areas we're considering compressing some just because there have been so many. And there's some things that are a bit overlapping. Like if you can see, like, we've heard a lot today about obtaining, and as I was saying, like the lack of documentation, it could be maybe shortened into like documentation and entitlements. Livelihood, supported return to work. So we have some areas where we can condense and then send out, but we're also going to be asking about the ethical dimensions of these interventions. So that relates to importance and feasibility. It relates to the relationship between importance and feasibility. And just to say that this Delphi analysis is helping to inform the HOPE intervention development planning process in each of the 3 countries. And I just wanted to add that as our Ghana and Kenya PIs were unable to join, that each country is developing different interventions based on what is found locally in the first stage of the formative research. So I just wanted to add that. Yeah, I think we're done.
So we just wanted to finish saying thank you. Yeah, we had hoped to have a discussion, but we have 2 minutes left. So if you have any feedback at all on the process, so the theory of change, the lead, context mapping, or feedback on the Delphi, we would really appreciate to hear your thoughts. So please feel free to approach any of us throughout today and tomorrow. So thank you again.
Thank you so much, Lauren. Really appreciate that detailed presentation on kind of the work, the extreme work that's going into ultimately figuring out what's feasible and scalable and applicable in multi-African settings, and the kind of care that's being taken to include the community, include elements of peer research in a very sensitive, in a very culturally sensitive way across the three countries. And we look forward to working with you more. I heard from Dr. Ramesh that there's interest. Appreciate you going on the site visits yesterday and appreciate your time. At this time, I invite back Dr. David Henderson onto the stage along with Dr. Piero D'Angelo for a short Q&A. I'm going to open it up to the audience and anyone who has questions for the excellent presentations and symposia we've had. So welcoming Dr. Piero back onto the stage as well. Thank you.
Hi, I'm Fabida Arya, consultant and medical director at UK Birmingham and Solihull Mental Health Trust. It's a question for Dr. Piero. In the UK, I've worked in a team as a psychiatrist alongside the police and the drug and alcohol services. So I wonder if you have anything like that, because that really helped us keep a lot of people away from hospital, get their needs met in the community, and the right person engaging with that person depending on their need. There were also a lot of people who kept repeatedly attending casualty or accident and emergency. So just going out to them and working in the community with them really helped us to get their trust, engage with them, and look after them in the community. I don't know if you have anything like that in any of your areas.
Thank you for the question. So as it relates, so field response or crisis as they relate to drugs and alcohol, and how to handle situations where the crisis is based or heavily influenced by drugs and alcohol. So in recent years, our law enforcement has actually become much more inclined to treat inebriation and severe intoxication as a psychiatric crisis. So a lot of times that person may end up in an involuntary psychiatric hospitalization, which then, if indeed it's solely based on intoxication, upon becoming sober or clearing up, they will probably just be released. Maybe they'll be provided with some referrals. We do have a very serious, in essence, epidemic involving methamphetamine, which is a horrible drug and can make anyone in this room, after about 3, 4, 5 days of usage, look indistinguishable from schizophrenia, right? From a florid, psychotic state. So methamphetamine has caused a lot of problems. A lot of those people will end up in jail. If there is any good news in this, is that from jail, people are usually diverted to programs. So that's the small glimmer of good news, is that there actually are a lot of programs where people are directed into treatment. Sometimes even better treatment than you can attain on your own if you're not in jail. Thank you.
Hi, my question is to the HOPE team. I wanted to ask, how did you go about selecting individuals with lived experience, and how many were there among the 3 countries, and did you ensure how did you ensure diversity, if at all that was one of the criteria?
Thank you for the question. So, how we recruited people with lived experience is that we have, for example, for Ethiopia, we have the Mental Health Service Users Association, which is a user-led organization focused on advocacy, peer support, training, awareness raising, etc., and research as well. So it was easy for us to pick people from there, from the association. So we did that. And for other countries, we have people involved in the research projects, in other research projects. So we brought them on board from other projects as well. But the issue is we haven't yet recruited persons with lived experience of homelessness. The lived experience advisory group are all people with mental health conditions. So what we want to do is, especially related with the ethnography, we want to recruit people with lived experience of homelessness from the ethnography. So that's what we will be doing next. Thank you.
Sorry, I'd just like to add one small detail. Across all three country sites, that is Ethiopia, Ghana, and Kenya, we have service user organizations that were onboarded by HOPE. So that means in every country there is a representative service user organization which links the individuals with lived experience that Eleni has just explained to the project and so on and so forth. Thank you.
How many numbers of individuals with lived experience have you planned to recruit?
So we have 2 per country plus me.
Okay.
No, it's also a continuation question to the Hope. All interesting presentations, and because the expert by experience is a new thing, and also it corroborates with what Dr. Vandana mentioned in the morning in terms of co-construction. So curious to know about it. And also you said in all the phases, League is part of the team right from writing proposals. I just want to understand in the process, did we reflect on the language we use? Because it's also top-down and professionally driven language, which constantly alienated and also looks at only deficit. So has there been any change, reflection in terms of the language that we use, which is clinical, top-down, deficit-driven, and whether the League's participation has made a dent to that?
Yeah, that's a very good question because it is challenging, people with lived experience have their own expertise to offer, but sometimes you see that there is a power dynamics attached to it. But the fact that we are there as a group has really contributed to our legitimate place to be recognized within the HOPE project. So normally we have, whenever we have a very specialized discussion, for example, in the measures that we are not familiar with, someone from the group, especially from the investigators meeting, will come to our own meeting to have a preliminary presentation on what will be discussed next in the investigator meeting. So we are acquainted with the discussions lowered to the level of not jargons, but leveled to our level of acquaintances and engagements in the project. Thank you.
For the project HOPE, for the ethnographic formative research that you have till now, have we included persons with alcohol and drug abuse problems? A. And B, if at all, there are people there who are also recovering persons working as counselors.
I just did not really get the question.
Oh, have we included people only with severe mental disorders or also with people with alcohol drug abuse problems? And two, there are also people, I guess, in Africa, recovering persons working as counselors or treatment professionals.
Yes.
Thanks. Oh, sorry.
So for now, we have only included individuals who have previous history of mental illness, not substance use. Not that we're definitely looking for that. It's just the kind of individuals we recruited. But we have in the League some individuals who have comorbid substance uses. Yeah.
There is one more. Yeah. This is for the HOPE. This is for the HOPE. In your group, that lived experience, do you involved in any sorts of economic empowerment program? If yes, you can share that experience also, if there is.
Could you repeat the question?
No. Is there this group, lived experience group, do you also encourage any sort of economic livelihood empowerment program?
So our Ghana representatives who couldn't be with us today are part of an organization called Basic Needs, and their primary sort of what they do around Ghana is around livelihood, community-based interventions and livelihood and scaling up like training for all of that. So yes, to make that a longer version of a shorter answer that could have just been yes. It's important that we do that, and we all know that it's part of sustainability.
My question's for everyone, and it's specifically about mental health for children. So if we are talking about mental health issues and housing for adults, we need to talk about the elephant in the room. Some of these issues are present when they're children. And how do we deal with those in order to not then start to deal with, the issue of they're 40, 50, 60, and then we're starting to interact with them on the street, when we could have dealt with some of the issues when they were children and help the family, help this person to stabilize before they end up in the situations that we find today.
Yeah, this is a great question because, as you know, many mental health or psychiatric disorders develop during childhood. And sadly, the world is way, way, way behind around mental health for children and adolescents. Like many countries, there's no expert whatsoever. There's no capacity for even a hospitalization for a child who's suicidal and so on. So we have in my global work, this is one of the areas that we're pushing for simply because there's just no care available. And so, if we get to prevention, we have to get to the children and adolescents. If we get to early intervention, we have to get to the children and adolescents. And for me as a psychosis person, I want to get them earlier and earlier and earlier. It's absolutely critical because now we have data that suggests if we intervene, maybe we can change their course and so on. My big answer is that we're just way behind, and really there needs to be a considerable efforts focus on children and adolescents, but at all levels of degrees and skill and that sort of stuff with comprehensive programs. But many countries, certainly lower and middle income countries, there's just very little services available. And even in the US where there's a lot, supposedly, it's really difficult to get somebody care, a child and adolescent, the appropriate care. So, thank you.
I would concur with that. The one glimmer of hope. So I would agree that formalized treatment providers are at a critical shortage, but we are seeing an incredibly larger amount of social workers inside schools. So there is a lot more, and actually even beyond where there was none before in a lot of schools. There were no social workers in schools, and my wife works in the schooling system, and I know through her experience in the past about 5 years, there has been an exorbitantly higher level of presence, actually from no presence of social workers to 2 or 3 years so. So, but they may not necessarily be involved in treatment. So that's, yeah.
Yeah, if I can add some. So Dr. Hendricks mentioned some countries don't have any resources. We are some countries. For example, in the hospital that I work in, which is the only specialized hospital, we have no adolescent unit. And we have only one psychiatrist who's doing adolescents and children. So resources are extremely limited. We know it's a problem. In the CAB meeting that we had, the community advisory group, that's exactly what they asked us. Why don't you include children and adolescents? But we don't have any structure in place. So we said for now we should start 16 and above. So what we do now is 16 and above in Hope.
This is about what you call sectioning in the UK. How does it work now? Has the threshold been raised or lowered? Who gets to decide that this coercive step that somebody needs to be, quote, sectioned? And for the other countries, if you could relate to that.
Luckily, I have not been sectioned in the UK, so I can't answer your question since living abroad. I could answer for America. I'm sure so could Dr. Henderson, but not for the UK. Lauren, do you know? Yeah.
Yeah.
We could answer for Kenya, Ghana, and Ethiopia, just not the UK.
Yeah, I would just say in the U.S. it's a MD or PhD or nurse practitioner or police can section someone to an emergency room for an evaluation. It doesn't commit them to the hospital. It commits them for an evaluation, and then the clinical team, MD or PhD, in the emergency room determines whether the person needs to be in the hospital or not. And if they determine that, then they're committed on a 10-day committal. But if the person signs in upon the hospitalization, they can get out in 3 days. They can sign out in 3 days. So really, it's a 3-day commitment for an evaluation. So. What's that?
In answer to the question, let me just say, what is meant by sectioning in the UK context is subjecting an individual to detention in hospital for involuntary treatment. It's just part of the sections of the Mental Health Act. So that is why it's called sectioning. And sectioning is a product of a decision, a recommendation made by 2 doctors, one of whom should be an expert, i.e. a psychiatrist, and another a general medical practitioner, and approved by a social worker, an approved mental health practitioner. This is the usual way of removing somebody from the community, detaining that person in hospital, and initiating treatment against that person's wishes. The police, however, also have the power to stop someone, detain someone for a short period of time if they suspect that individual has got mental health problems. The courts in the UK can also order somebody to be admitted to psychiatric hospital for the purpose of treatment. So there are different routes into sectioning, but the most commonly used one is by psychiatrists and the general practitioner detaining someone to hospital, initially for a period of 4 weeks, but can be extended after that quite indefinitely. Unfortunately, there's a substantial number of people who are detained in hospital under sections of the Mental Health Act for considerable lengths of time. And even more unfortunately, your risk of being detained under the section of the Mental Health Act and staying in hospital a very long time, the rates are disproportionately high, as David mentioned. In the United States, people of color, people from lower, poorer social backgrounds, and people who are otherwise marginalized within the society.
Can I? Okay. No, just a question. I was trying to reflect if there is a factor which is in common to the presentations that can be maybe not expressed fully. Maybe that's just a small provocation for the discussion, which is the system of values, which is behind research, which is behind mental health practices, including the very nice presentation that Piero has done about ROAR. So having more refined technical instruments or technical instruments for research, even in more inclusive research, including peers, if we don't reflect on the values which are overarching all these practices, because I think it's not enough to talk more attention about advocating for mental health care. It's too generic. This is linked to other factors, which are societal factors, etc. And I think homelessness is a kind of question that brings these factors into the discourse very much. And I'm afraid we cannot avoid to express our preliminary principles, let's say, that bring us into this field and bring the values into the discourse, which are very fundamental, in my opinion. I don't know what some of you think about this. Thank you. Not just human rights, but also broader values.
Yeah, my name is Mariam Swami. I am the Banyan, one of the resident. But today I have a lot of good thing to learn, and I think I know just a little English. For that, today I'm feeling very happy with different country. They have come and they give the speech. It is a very meaningful and very understanding for ours and for the people who are staying, and mostly for the homeless people. If I said anything wrong, I'm sorry, and thanks to each and everybody.
Thank you. I think we'll take one last question
you.
before we break for lunch. Thank you.
Yeah.
Okay, we'll take two last questions before we break for lunch.
Okay, yes, to acknowledge, I think that, I guess, you're right, like, the basic is, human rights is at the, a key component to all of this, but I certainly talked about equity and health equity, and as you know, like, if somebody has mental illness, they're already in a marginalized population. Their health outcomes will already be worse, as we've heard, and so on. And so, but it is, I think so. So I mean, that's one of the important values that we focus on. But again, like in my global work, I never, I did a lot of work in low income countries and post-conflict and so on. So I could never actually talk about human rights as the work that we were doing, but I knew we were doing human rights work, getting people the basic needs and that sort of stuff. But I can never say it because then the government would look at us in a different way, like we were trying to find bodies and that sort of stuff. But that, for me, that is the basic. Like every person deserves to, have the opportunities to have a, healthy life and shelter and relationships and all that, all the things we can take for granted and that sort of stuff. So, but I, again, I think everybody in this room probably shares a lot of the same values.
Hi, this is Dr. Sutapa Majumdar, and I am with LEAD at Kriya University based in Delhi. This question is for Dr. Henderson. You touched upon the issues of loneliness as one of the reasons of mental health stressor. I just wanted to maybe ask you that in your entire career of, as a practitioner, do you see that there has been a change in terms of issues that are coming up? For instance, now we know that there is a global geopolitical and economic crisis. Does that impact mental health? And do you come across such people and cases in the US? And also you briefly touched upon race. And I was wondering that in terms of race people suffering with mental health issues, do you find that there are certain treatment gaps that are there? And how if it is there at all, what are the ways to get into the intervention. I'm also interested to understand the impact of climate change, if you could just, and on in mental health, if that is something that interests you. Yeah. Thank you.
Okay, thank you. We're going to take up another hour here. And I'm happy to talk to you because it's a lot of interesting things. Like, first is like the changes and trends, like what's interesting from our emergency services data is that I'm a psychosis person. Like, I treated schizophrenia, and I thought, well, it's going to be overwhelmingly schizophrenia that we've been intervening. It turns out it's depression and anxiety. Like 45% of 120,000 people. But the psychosis, which is really it's important data, the psychosis came in second, but it actually had the most repeat visits. And so what it told us is that we're not doing as well for our individuals with psychosis. So we have to, like, whatever programs we have, they're not working because they're not catching on because they keep ending up in the emergency room. So we have to kind of go back and take a look, and we started looking at our data and see where we were dropping the ball, and sometimes it was housing, food insecurity, that sort of stuff, or couldn't get them back to school when if it's an early psychosis. So there's a whole bunch that we can learn from that. And then as your last comment, and again, I would love to talk to you because there's so much to talk about, but with our database, we're now able to put climate data on top of our database. So we have a longitudinal database, about 20 years, about 120,000 people, some with multiple visits in acute crises, mental health crises. And then we have the climate data. So we're now, one of our colleagues got a NIH grant. So they're now looking at, extreme temperatures and seeing, whether that actually impacts encounters through the emergency services, like high temperatures, low temperatures, and so on, which certainly could be a factor. So anyway, if you're interested in that, come talk to me.
Yeah, so I was just wondering, I do know that we mentioned children and adolescents, but in terms of care providers, we mentioned, we refer to institutional care providers largely. What if, in the context of family care providers, children with parents with mental illness or elderly care providers, in such contexts, because we're engaged in some of this work, is there an approach that's integrated into your programs that services the needs of such persons? Because loneliness, distress, and many other aspects that we referred to are very applicable to this group.
Our group HOPE is not looking at children, specifically operationalized as 16 and above. In general, and Dr. Ibka could speak about this, and Eleni, more than I could, there has been a lot of work around family support, and there's currently a project that's being funded on early identification of autism, which again isn't the same thing as exactly as we're talking about. But so there are small steps, but mostly it's within the family and trying to have family support, psychoeducation, and those types of things. It's in the countries that we work in, the issue of street children is a very different type of issue than adults with severe mental illness. And so for the purposes of HOPE, we made that distinction.
Yeah, and I would say in the US, I think we've made some progress because there's some government support for, like if you have a family member with a mental illness or a disability, there is funding for, so individuals, somebody in the family actually gets paid to take care of them up to 40 hours a week and to do, whatever is necessary to keep them well and so on. So that's actually a pretty nice government feature that we have that's actually been quite beneficial. Also, many of my patients with mental illness, they're actually taking care of their parents or and so on. And so they have a source of income. They're in with the family unit as well. They have housing, and so it all works out pretty well.
That's great. I just have one last question. I'm just wondering, this may be a stupid question, but is there any way in which the police can be completely out of the system as first responders?
I'll say quickly, what we've done is we have like this, it's called the National 988. Somebody can call in a mental health crisis, and it's diverted from the police. So actually, mental health professionals get it first. And so what we've been piloting is to have our clinicians go out with an ambulance as opposed to going out with the police. Of course, we have to evaluate the situation. If it's considered extremely dangerous, then the police have to go. But we've been able to reduce the police calls going out by at least 50% by our clinician going out with an ambulance.
Yeah, the trick is in distinguishing a crisis versus an emergency. So that has to be properly triaged at dispatch when the call is received. Because a crisis can be, I have exhausted the abilities to contend with my own internal difficulties, so I'm not sleeping well, I'm in distress, versus an issue relating to safety. If it's an issue relating to safety, police pretty much has to respond.
Thank you. Thank you, everyone. Really appreciate your time on the stage.